Assalamu alaikum. Good morning, good afternoon, good evening, depend where you are locating. Welcome you all to the second session of the Jardiance Heart Failure with Reduced Ejection Fraction webinar and sponsored by Bringer in association with the Saudi Heart Association. Welcome you all to the second seminar webinar. Today we have a very exciting webinar about heart failure with reduced ejection fraction with an eminent speakers from across the world. Without further, I will start introducing, we have 3 talks, then we'll have a question answer. Please kindly, if you have any questions, burning question, you have the Q&A button in there. Just please send your question. We'll send it and we'll try to answer it and throw it to the speakers as we're going on. So without further ado, I would like to introduce the first speaker, Dr. Ayman Morsi. He's the head of cardiology from An-Noor Hospital, and he will give us a talk about unmet need in heart failure management. Dr. Morsi.
Okay, thank you very much for this nice introduction, and thank you very much for Boehringer Ingelheim to give me this excellent talk. My talk is simple as usual, the unmet need in heart failure. My agenda, very simple, incidence and the prevalence of heart failure nationally and internationally. What's burden of heart failure in regard to the general burden, hospitalized and rehospitalized and the deaths, quality of life, and I think all the heart failure specialty colleagues, we want to know what we mean by this equation, which is DLY equal to YLD plus YLA. DLY, I can give it in the next lecture. Economically, what's unmet need and what is the solution then? And lastly, not least, take-home message. I think the incident and the privilege, you can see here, according to circulation, according to AHA statistically update in 2019, they mention elegantly 6.5 million people diagnosed with heart failure and approximately 1,960,000 new heart failure per year, and the 24% readmission within a month of discharge, and the 60% rehospitalized for heart failure within a year. And this number is everything is supposed to be booked, 50% in 5-year mortality. Very high burden. 50% of all heart failure patients is died within 5 years. This is one prevalence of heart all over the world here. In North America, for example, around Canada, 1.5%. In Europe, around 1.2. In UK, 1.3. In Asia, like Malaysia, is 6.7%. In area here, Middle East is around 0.5. According to the incidence in compared to the prevalence, which is again importantly 0.1 to 0.2 in Portugal, in compared to the prevalence percent is 1 to 2. In, for example, here in USA, the incidence 0.1 to 0.2, and regard to the prevalence is 1.4 to 1.9. According to here, according to our area, Journal of Saudi Heart Association mentioned elegantly about the heart failure in Article 18 in 2020, mentioned about the age of heart failure population in our era. For Saudi Arabia, for example, the age of heart failure is approximately in 55.6 aging. In Egyptian registry, around 57. So most of Gulf area is 59. In compared to the USA, for example, the age of heart failure 75 and Europe is 71. Why in our area, most of heart failure in Middle East is coming early, mostly due to what we can say the risk factor and the risky behavior of cardiovascular is very valid in our area here. You can see here low physical activity, approximately 70% of our area is low physical activity. Obesity, which is very high here, especially in ladies. Second thing, unhealthy diet is very commonly, especially in male, and so on. The general burden is 1 on 5 patient heart failure development, around 30% readmission within 90 days. And again, the huge burden, it is the first cause of hospitalized in age more than 65. And most of the budget, 80% of direct cost of heart failure due to hospitalization, and 30% dying within a year. Believe it or not, you can see elegantly here what we mean by the burden. The burden here, 5-year mortality in patients with heart failure exceed all of type of cancer. You can see here around 50% in a 5-year, in compare all these type of cancer, even leukemia around 40% in compared to 50% under heart failure. So it is magic issue. According to the number and the hospitalization, approximately very huge the number and the proportion of hospitalization, as if you can see here. Lastly here, heart failure and hospitalization, you can see in Norway, for example, 1.1, in Poland, 1.9, again in England, 1.4, even the study, it is not 2, 0, and 11. So these magic slides, and I want everybody is supposed to be concentrated about how heart failure is very high risky. If you are treating your patient very well, according to the guideline therapy, still 9 of 10 of patients are symptomatic. 1/3 of them, according to the FIRM study, you can see nearly 1/3 of the patient have high risk of hospitalization or cardiovascular death. And this very important thing, for each heart failure hospitalized, the patient lost his age. For example, after first one heart failure hospitalization, our patient lost around 2.6 years. In the second heart failure hospitalization, 1.8 lost again. So mean if our patient have 4 admission, so he lost around 8 to 10 years from his life. That's why we can say here approximately the same. So if our patient have 14,374 in the first admission, and the patient go home, if for repeated hospitalization, the number is decreased from 14,000 to 3,000 only. Third hospitalized, the 14,000 is become 1.1 only. Fourth hospitalization from 14,000 to 417. So repeat hospitalization mostly is associated with increased mortality. Again, if you are very perfect heart failure specialty colleague, and if your patient go and decompensated heart failure and go to hospitalized, when you are managed him very well, your patient cannot go to his baseline again. Meaning what? For each cardiac event, for decompensation, your patient lost myocardial injury, which may contribute to the progressive LV dysfunction up to death. Approximately here the same. Even in newer functional class, stage 1, stage B, for everything hospitalized, you can see the progression of remodeling up to the patient go to stage C and D, and the patient can go quickly for death. So the heart failure, according to the burden, you can see 4 to 10%. If you diagnose patient de novo, 4 to 10% mortality rate in first hospital. If your patient go home, 30 days up to 10 to 16% mortality rate after 30 days. In a year, up to 30%. And this is a magic issue, 550. Before the concept we mentioned before, our concept is heart failure with reduced ejection fraction is more harm or more risky than the risk of other staging of heart failure or other type of heart failure. But the reality is no. All type of heart failure, the mortality and readmission and the cardiovascular readmission approximately the same. So heart failure with reduced ejection fraction mortality or borderline or mid-range or mild reduced now called 75. So all the type of heart failure is the mortality and readmission and the cardiovascular admission approximately the same. So heart failure is heart failure. So it is one of the most common causes of hospitalized more than 65. And this important thing actually, length of the stay approximately 5 to 10 days, which is consuming our resources. And my important thing, which we want everybody to know, is de novo heart failure cases, it is approximately up to 30% of all causes of hospitalization. So de novo is important. So this is the length of the stay. So most of the study mentioned here, most of 1 to 3 in America, they mention around 7 to 10 days. In France, for example, the length of the stay may be cross 10 days. Approximately here is the same. Definitely, you will agree with me, the vulnerable phases after discharge is only first months. So the first 30 days is one of the important vulnerable phases after discharge for patient get to re-hospitalized, especially for the heart failure deaths in compared to the sudden death and all cause of cardiovascular death. These very magic slides, actually, you can see, and we have to predict our future, sorry to say, but this our future, honestly. You can say here, this number of the people in vertical axis here, which is the number of the people times 10,000 in compared to the horizontal, is the years. You can see we started in 1960, the number of the people is 16.6 only, and then go quickly to 25.5 in 1980s, and then 2000, there is increasing the actual burden here, and it is become panically increased to 34.8%. But this our future, and sorry to say, in 2040, you can say here 77,000 projected new heart failure cases in 2040. So magic burden, as if you mentioned. These studies say, I mean, this quickly can say, this patient with depressed heart failure as regard to quality of life. What he say here, we only live once, but this one is heart failure patient, but not depressed. What he say, wrongly, you are fully wrongly. We only died once and we live every day. So according to the ACHA or Circulation 2021, health-related quality of life and mortality in heart failure patient, globally congested failure study in 23,000, they mentioned quality of life is very strong and the independent predictor of all cause of death and heart failure hospitalization. Again, it is believed with European Society of Cardiology even approximately the same. The impact of chronic heart failure in health-related quality over burden of the disease is comparable to the other chronic diseases like Parkinsonism. So you believe it, heart failure is associated, how is affected quality of life? You can see here 67% of heart failure patients find too difficult to carry usual his daily activities. 50% of them have an anxiety and depression. And you can see here, 66% have mobility. So this is for improving heart failure symptom and the quality of life. It is important like mortality exactly. These slides, I want to all heart failure specialty colleague to be knows well what we mean by DLY equal to YLD plus YLL, meaning that disability adjusted life year is measured all over the disease burden, expressed as a cumulative number of years lost due to disability. This DLY equal to how many years a patient live with disability plus year life lost, meaning if you can watching with me here, this is a normal life and the patient is starting to be heart failure here and they start you book him as if he have disability. So his life is affected fully. So he died here. So he lost it all this year from his life, which is called YLL. This exactly what means the disability of patient of heart failure. Economically, I think everybody knows in European and heart failure society and globally they mention 1.8 billion per year, which is published in a Journal of Cardiology 2014. And again here in 2020, they mentioned the annual total medical cost of heart failure care were estimated around 24,383 per patient. Right? So what is the cost, which is always more than 60% or 50%? It is mostly due to hospitalization in compared to the other costs like drug, only 9%. Outpatient visit is only very, very low in compared to around hospitalized around 60%. You can see 1% of total budget coming from hospitalization of heart failure patient. So what's unmet need then? Unmet needs, and there remain big gap or unmet need to improve the care for patients with heart failure, even heart failure with preserved function or heart failure with reduced ejection fraction. The patient with heart failure with reduced ejection fraction, as mentioned, 5-year mortality more than 50%. Even the patient with heart failure with preserved function, I think you are agree with me, no actually treatment option identified today, except maybe Sj82 inhibitors. Treatment is reliable in management of comorbid only. So what is the solution then? How to solve this issue? The issue can be solved here by what we can say policy makers. I urge you to make a recommendation, and I think you agree for prevention as a top of this recommendation. We need for prevention, optimize care transitional, improve end of the life care, and the number 4, provide quality care of all patients, and appoint an expert heart failure leader to be cross the discipline development and implemented better measurement of care quality, improve patient education and support, and lastly, not least, simulated research into the new therapy. What we need to overcome by what I said, physician inertia. So if you want to override this problem, we need everybody of us to go with, to guide the guideline and need to overcome in order to, we are one of the cause to make it what we can say that our patient is not treating well by what we can say physician inertia. And this is very clearly what I mean by physician inertia. In spite the guideline recommended therapy, most of our patients is not take the guideline directed therapy. For example, patient of heart failure, according to the CHAM heart failure registry, you can see here 39.1% of the patient of chronic HFrEF, it is no without any contraindication, is not given the medication, which is called physician inertia. And this very magic number, the key line of therapy, which is ARNI, which is called, I can say, mother of RAS blocker in HFrEF patient, 86.1% of them is without any contraindication, the patient is not receive ARNI. If you collected both together, which is RAS blocker, which is ACE, angiotensin blocker, or ARNI, you can see 26.2% without any clear contraindication is not given. Again, beta blocker therapy, 32.9, without any contraindications, the patient not receive it. And the magic issue, MRA group, which is very magic group, which is number 4 in Peru, 65.9% is not receive the guideline therapy, also without any clear contraindication. These slides, I can say it is important slides in order to, as a cardiologist or as a colleagues to treat the heart failure, what you call inertia from physician. So what's take-home message, our colleagues? Again, frequency, 64 million people worldwide, around 1 to 2% global population. I think it's become 30% in around 20 to 25. 9 of 10 is still progressively diseased patient have symptom in spite of therapy. Mortality is very high. And I show you now what we mean by 5-year mortality, around 50%. Costly, again, it is very costly. I can say openly now, frequently is high, progressively disease, deadly disease, and it is costly, but it can be preventable and treatable. So what we can say, prevalence of heart failure continue to rise, causing considerable morbidity and mortality. Use the available weapons we have against heart failure. Don't forget the policy, which is always the act urgently, which is 8 recommendation, as if I show you now. We need to overcome what we call physician inertia. And lastly, not least, I want to say something here. If we want to win the war against heart failure, science will be compound, and please follow the guideline medical therapy, any guideline you want, which you can change the heart failure to what we can say heart successes. And thank you very much.
Thank you. Thank you very much, Dr. Morsi, for this elegant presentation and overview of the heart failure and the unmet need in the management. And you nicely, elegantly highlighted the magnitude of the problem nationally, internationally, and the unmet need and the gap in the management and the problem. Before we move on, we have a question. Welcome Professor Mustafa Shememri with us in the webinar. He sent a burning question. Dr. Morsi, don't you think the prevalence of heart failure in our area, 0.5%, is underestimated?
Excellent. It's a very good question, actually. According to the Saudi Heart Associations, in the last, which is I mentioned in slides number 4, I think this is optimal, but for me, it is definitely every year by year, the ratio is more and more increasing. But this is my data, which is available in my hand till now.
Okay. We'll keep the majority of the question at the end of the webinar. Thank you for sticking to the time, the 20 minutes we decided. Thank you. We'll move on in the program. Our next speaker is Professor Javed Butler, is Professor, Chairman of Department of Medicine, Professor of Physiology, University of Mississippi Medical Center, and he's also the Patrick H. Lian Chair in Cardiovascular Research. His research interests focus on clinical trial and patient with heart failure topics, and he was author more than 800 peer-reviewed published publication. And also previously he was served as the director of the heart failure research at Emory University and the director of heart and heart-lung transplant program in Vanderbilt University. Professor Butler will give us a talk titled Deep Dive and Emperor Reduced Trial Sub-Analysis. Professor Butler.
Well, thank you very much. I very much appreciate the opportunity to be talking with you today. I had the absolute pleasure of serving on the steering committee for the Emperor Reduced trial. My disclosures are at the bottom of this slide. So let me quickly start by discussing why are we talking about using a drug which was developed for the management of patients with diabetes in patients with heart failure to begin with. And this all started with this trial called Renal Outcomes trial, which was sort of the first trial in the history of mankind that showed that in patients with type 2 diabetes who are at a high risk for cardiovascular mortality, and in fact, cardiovascular mortality is the #1 cause of death in these patients, that you can reduce the risk with the use of empagliflozin. But more pertinent to our talk today is shown on this slide that in this trial, we also saw a significant improvement in the heart failure risk. The curve started separating early, continued to separate. But what was interesting was that glycemic control, either the hemoglobin A1C at the beginning of the trial, end of the trial, the change in hemoglobin A1C, none of them correlated with this benefit. So clearly the benefit was beyond glycemic control itself. So that led to a whole lot of studies in animals and in humans. How do these drugs work is a full 1-hour discussion in itself. Suffice it to say that these drugs have been shown to improve cardiac structure and function. So LVH reversal, reverse remodeling, increased EF, volumetric changes, fibrosis, diastolic function. They are associated with improved vascular structure and function, so endothelial function, aortic stiffness, renal structure and function, decrease intraglomerular pressure, renal preservation, osmotic diuresis, natriuresis. And they have a whole bunch of systemic effects like oxidative stress and inflammation, improved mitochondrial efficiency, maybe related to low-level ketones, maybe low-level fatty acid oxidation. But if you put all of these things together, we will never find a way by which these drugs improve outcome because the biology is complex and all of these things work in an interdigitating fashion to improve the outcomes. But the bigger question is that if a drug can do all of these things, what does this have to do with diabetes? Sure, great diabetes drug. I already mentioned significant reduction in cardiovascular mortality with the use of empagliflozin in type 2 diabetes. But when we start talking about cardiovascular diseases like heart failure, maybe what we have is a cardiovascular risk modifying agent that will work across the spectrum of heart failure patients with or without diabetes. So with that background in mind, pleasure to present the Emperor Recused trial. This trial was designed to answer 3 questions. So patients with heart failure, reduced ejection fraction, EF less than 40%, or 40% or less. 3 questions. Primary endpoint, does this trial impact on cardiovascular mortality and heart failure hospitalization? If that is positive, what about total heart failure hospitalization first and recurrent? And if that is positive, what is the impact of this drug on renal preservation in patients with heart failure who have a special cardiorenal link? The patients, so over 3,700 patients randomized to empagliflozin versus placebo. These are the baseline characteristics of pretty, usual heart failure population that you might expect. About half of them had atrial fibrillation, half of them had diabetes, mean EF around 27%. But what is important to note is at the bottom of the slide, and that is Dr. Morsi already mentioned that patients in the clinical setting don't get a lot of good therapy. There is inertia. But in the clinical trial setting, you try to make sure that the patients are on a best possible medical regimen so that whatever the benefit you get, that is incremental to already very good medical therapy. So you can imagine that even if you're not on good therapy, the benefit may be even more. Here, we have close to 90% of the patients on RAS inhibitors, 90+% were on beta blockers, and 70+% were on mineralocorticoid receptor antagonists. So if you put together excellently treated patients at baseline were randomized. So what did we learn? So this is the primary endpoint. There is a saying in the clinical trials world that if you need a p-value to prove your point, maybe your data are not very strong. And here we can see the curve started separating early, continued to separate a highly statistically significant and a highly clinically relevant 25% relative risk reduction for these patients. This also highlights that there is no such thing as a stable heart failure patient. Despite of the fact that these patients were outpatients, not in the hospital setting, and were excellently baseline treated. Look at the one-year event rate for the primary endpoint. Almost 20%, or 1 in 5 had a one-year event rate in this trial, reduced by 25% relative risk reduction. So now that we have met our first primary endpoint, what about the total heart failure hospitalization? That was reduced by 30% relative risk reduction, even a greater benefit, 30%. Again, curves started separating and continued to separate. So that takes us to the renal endpoint. So few things to note before we go over the results. One is that ACE inhibitors, we know, are in the long run good for the kidneys. They preserve renal function. But in the short term, when you start somebody an ACE inhibitor, you see a little bit of a creatinine bump or a little bit of a GFR dip. That is not hurting the kidneys. That is intraglomerular hemodynamic changes that reverses when you stop ACE inhibitors. Sj82 inhibitor, the same thing. You start an Sj82 inhibitor, you get this initial dip, then you get preservation of renal function. And then at the end of the trial, when you stop an Sj82 inhibitor, that dip comes back. The second thing to notice before we go over the results is look at what's happening in the placebo arm. It's not that the placebo arm was not getting anything, but despite of almost 90% RAS inhibitor use and 70% MRA use, aging, heart failure, and comorbidity-related decline is very evident in the placebo group, which was preserved with the use of an SGLT2 inhibitor, empagliflozin. What was the magnitude? The magnitude was 1.73 ml per minute per year. In other words, the age, comorbidity, and heart failure-related decline was slowed by 1.73 ml per minute per year. Now that, as a clinician, as a researcher, as a trialist, is really, really exciting result for me. But our patients are asking, how do you translate that into a clinical benefit? What are my risk of needing dialysis, transplantation, end-stage kidney disease? And that risk was reduced in half, 50% relative risk reduction with the use of this therapy. So in short, the EMPEROR-Preserve trial was designed to answer 3 questions: cardiovascular mortality, heart failure hospitalization, total heart failure hospitalization, and eGFR preservation. All 3 of them highly statistically significant, all 3 of them highly clinically relevant, and the eGFR slope translated into a 50% reduction in the renal endpoint. What about time to first hospitalization? Again, this highlights how early you get the benefit. The curves started separating pretty fast. Now, the heart failure hospitalizations can be across the spectrum. On one hand, you have the really sick patients in the ICU needing IV pressors, vasodilators, inotropes. And on the other hand, you have the patients, maybe outpatient IV diuretic, maybe just in the emergency room and you send them home. So does empagliflozin improve outcome across the spectrum? So here are the really sick patients requiring IV vasodilators, IV vasopressors, IV inotropes, and one can see substantial benefit, 36% relative risk reduction. And here is the other end of the spectrum, not so sick decompensation, 33% relative risk reduction. So not only do you have a very clinically meaningful reduction, the reduction is across the spectrum of the level of sickness as well. How quickly do you see the benefit? Well, we measured New York Heart Association class at week 4. And one can see here that even at week 4, there's a substantial improvement in New York Heart Association class and a substantial worsening with the use of placebo, and those changes are preserved over the course of the trial. How early do you see clinical benefit, not the quality of life or the symptom benefit? And again, if you look at the Kaplan-Meier curve, the Kaplan-Meier curve for the first time became statistically significantly divergent in less than 1 month, less than 1 month. So these things work and work pretty fast. So then the question is, did our experiment that these are cardiovascular risk modifying agent work out irrespective of diabetes? Did patients both with or without diabetes benefit from this drug? So as expected, patients with diabetes were at an absolute higher risk as compared to those without diabetes. But the relative risk reduction in the cardiovascular outcome was seen in both groups. The p-value for interaction highly non-significant. Both groups of patients had significant benefit in terms of cardiovascular death or heart failure hospitalization. Well, one can argue that the dichotomous differentiation, diabetes, no diabetes, is a little bit artificial. What about trichotomous, diabetes, prediabetes, no glycemic abnormalities? Well, why not just look at hemoglobin A1C across the spectrum? And as is seen here, again, at two ends of the spectrum of any continuous variable, the confidence intervals are wide because you have a lot of people with hemoglobin A1C of 6.5, 7, 7.5, but not too many with 4.5 or 11. So the confidence intervals are wide, but one can see no heterogeneity, straight benefit across the spectrum of hemoglobin A1C, proving that these are truly cardiovascular risk modifying agents. If you give it to a patient for diabetes, for the management of diabetes, great option, but for cardiovascular diseases, irrespective of diabetes, do the work. Now, patients with diabetes are at a high risk of kidney disease. Everybody knows that. And therefore, it's of interest to see if you have a combination of diabetes and CKD, will the drug work? But what about those patients who do not have diabetes but have heart failure, and heart failure itself leads to worsening renal function? So do you see the benefit in both? So I already showed you the data for cardiovascular outcomes in those with and without diabetes. Here are the renal outcomes with and without diabetes. Both groups of patients benefited from renal function preservation. Both groups of patients benefited from clinical renal events as well. Of course, the renal event absolute risk was higher in those with diabetes. The other important group is CKD. Again, heart failure and CKD have a bidirectional relationship. Heart failure worsens the risk of CKD. CKD worsens the risk of heart failure. And if you have both together, the prognosis is much worse. CKD also not only leads to increase in sodium and fluid avidity, but also remember that CKD also prevents good heart failure therapy. As your GFR starts going low, you're unable to tolerate RAS inhibitors a lot. And in fact, MRAs are contraindicated in patients with GFR less than 30. One distinction that EMPEROR-Reduced trial has is that it went down to GFR of 20. So you can use it all the way down to GFR of 20, which opens up a therapeutic opportunity for patients that may not be able to tolerate or are contraindicated to standard medical therapy. More importantly, you could start empagliflozin all the way down to GFR of 20, but during the course of the trial or therapy, if the GFR falls less than 20, you don't stop the drug, you just continue it all the way up unto end-stage kidney disease. Once you have end-stage kidney disease, you're on dialysis, then at least today, the recommendation is to stop the medication. We don't have data. Now, in this trial, we define CKD as using the standard definition, GFR of less than 60 or urine albumin to creatinine ratio or macroalbuminuria greater than 300. And as one can see here, very similar to diabetes. Patients with diabetes are at a higher risk, but both diabetes and no diabetes patients benefit. Here, patients with CKD are at an absolute high risk, but the benefit, again, interchangeable, regardless whether you have CKD or you don't have CKD. Both groups of patients benefited from the use of empagliflozin for cardiovascular benefit. And what about renal benefit in those with pre-existing CKD without meeting the definition of CKD? Again, both groups benefited. So we are seeing pretty consistent benefit in this group. Now, Dr. Morsi made a very, very strong, cogent point about the importance of quality of life. So let's talk about that as well. So some of our friends on the call who don't think about quality of life all the time, that was measured in this trial with the use of Kansas City Cardiomyopathy Questionnaire. There are 23 questions in this questionnaire. Those targeting just the symptoms, symptom frequency and burden is called TSS or total symptom score. On top of symptoms, if you add physical limitation, it's called CSS or clinical summary score. And on top of the clinical summary score, if you add other domains like quality of life, social integration, that is called OSS or overall summary score. So there are two questions to be asked. One, in the beginning of the trial, are some patients too sick that they're just not going to benefit? They're just too far out. Or some patients too healthy, they're doing so good that they're not going to benefit. Well, the answer is that regardless of where you are on the spectrum, too sick or not too sick, empagliflozin improved cardiovascular hospitalization across the spectrum of the disease. So now the next question is, once you take empagliflozin, does the drug improve your quality of life? So we measured quality of life scores at 4 time points in the trial: at baseline, early at 3 months, intermediate at 8 months, and long-term at 12 months. And one can see here, right away, the first time when we measured it at 3 months, the benefit was already seen and was persistent and sustained up to 12 weeks without any diminution of benefit. Now, what does this mean to the patient? You know, very much like the eGFR slope that I was very excited about, but you need to translate that into what the patient means. So that's the risk of dialysis and transplant. So here, how do you translate a continuous scale of a KCCQ score for patients? Well, so you do something called a responder analysis, which basically means that what are the chances that you will improve by 5 points, which is considered clinically significant? Why? 5-point translates almost into 100 meters of excess walking capacity. 10-point improvement is really significant, sort of a wow level improvement. Whether you look at CSS, TSS, or OSS, whether you look at a 5-point or a 10-point threshold, at all levels, at all time points, there was more benefit seen with the use of empagliflozin in these patients and worsening with the placebo. And I again want to highlight, this is despite excellent baseline medical therapy. The drug was very well tolerated. The average difference in systolic blood pressure was less than 1 millimeter. Now, of course, we're not going to take a trial from thousands of patients and apply to the patient sitting in front of us. We'll use our best clinical judgment, but systematically, we did not have to stop any of the diuretics or drugs or anything like that. But of course, for an individual, if you have to do it, that's a different story. Now, my colleague, Dr. Bloom, will cover the guidelines in detail. All I want to mention here is that these data are already picked up by global guidelines. I had the honor and the pleasure to serve on the European Society of Cardiology guidelines as the American representative. And now, evidence-based SJ82 inhibitors are considered standard of care as a foundational therapy, not only as a foundational therapy, But even the idea of sequencing is gone, that you start this drug first and that drug later, and then, you know, add this on. But basically use your best judgment, tailor it to the patient sitting in front of you, just get all the 4 drugs, RAS inhibitor, beta blocker, MRA, and Sj82 inhibitor as soon as possible. And the reason for that is here. So here, the red line, the worst prognosis, is not HFrEF patients not getting any therapy. This is HFrEF patients getting very good therapy with ACE inhibitors and beta blockers, sort of the standard what we do practice. But on top of ACE inhibitor, beta blocker, if you switch to ARNI, add MRA, and add Sj82 inhibitors, you're talking about an increase in survival of over 6 years, over 6 years of survival added. Even octogenarians, people in their 80s, have more than a year of survival added. Also, our patients come in all different forms: high heart rate, low heart rate, potassium, creatinine, everything. So the European Society of Cardiology, HFA, had a very nice paper looking at various different phenotypes and how to match the therapy to different phenotypes. But what was one common denominator was SGLT2 inhibitor. Doesn't matter what your phenotype is, the patients could be started on empagliflozin for their heart failure. So this is my last slide. And I would say that if I were to go on the drawing board and come up with the ideal therapy for patients with heart failure, what would it be? Ideal therapy. Well, it's 1 drug, 1 dose, once a day. No up titration, clinical benefit, quality of life benefit, early benefit, safe and well tolerated. The reasons for which all the other therapies are sometimes not tolerated, like potassium and creatinine and dizziness and heart rate and blood pressure, none of those are issues. And while you're giving it for heart failure, you have a lot of side benefits in terms of adiposity and diabetes and chronic kidney disease. That drug would be an SGLT2 inhibitor. So I very much appreciate the opportunity to present to you, and I will have Dr. Bone now present some of the practical management and the guideline issues. Thank you.
Thank you, Professor Butler, for this excellent and light and imperative trial sub-analysis. Thank you. We got many questions, so we'll keep it until Professor Michael Baum finishes talk. So we'll move on to our last talk for the today webinar, which is titled SGLT2 Inhibitor and Heart Failure Patient Journey, the Clinical. It's going to be done by Professor Michael Baum, is a professor and director of internal medicine and cardiology and angiology and intensive care medicine at Saarland University, Germany. And also his research interests focus on vascular biology, pathophysiology, and gene expression in cardiac failure and hypertrophy. He's also the chief editor for clinical research in cardiology, and also he's a board member of many research board and the circulation research, hypertension, Lancet, and it's a very wealthy CV. Without further, Professor Michael Baum, floor is yours.
Excuse me. Thank you very much, Dr. Khalid, for this introduction. It's a great pleasure for me to talk to you about the journey and the patient journey with SGLT2 inhibitors. And I will focus in the following on these topics. So first, these are my disclosures. I will guide you through the principles of the old guidelines, in particular the ESC guidelines. I will then move to SGLT2 inhibitors along the story of cardiovascular disease. I will try to give you some arguments which have been already mentioned by Professor Butler, why heart failure drugs, and in particular the SGLT2 inhibitors, should start it early in the patient journey, and then how to layer treatments. And the last point is very important, as there are many discussions among physicians whether this is possible or not. So principles of the old guideline are depicted here in the 2008 guidelines and here in the 2012 guidelines. So the ESC guidelines were sometimes very conservative. So they always sequenced the drugs according to the time point where the evidence was generated. Furthermore, they copied the target doses which have been tried to achieve in the trials. So the recommendation was already to start with one drug and then to up-titrate it to the maximal tolerated drugs or even to the maximal doses, and then go to the next one So there was in the old guidelines a very strong and conservative sequencing from RAS inhibition to beta blockers, MRA, and then to subgroups such as patients with high heart rate, and this is ivabradine. So in 2012, the CVIS-3 changed it a little bit because it tested of whether it makes a difference to start with an ACE inhibitor and a beta blocker. So from that time point on, it was allowed to start with the two of those. However, now after having these discussions in the guideline committees, it came out that the people suggested that according to the slow up titration, which can cause months or even weeks at least, might cause events because the start of the treatment is postponed and rather late. So therefore, the new guidelines have changed this concept, and I think this strategic change is one which will really affect the outcome of the heart failure patient. So this is a new guideline, and that is what you all know, that we now start with 4 drugs, all have shown in more than 1 trials to improve cardiovascular death and heart failure hospitalization. And these are RAS inhibitors and ARNIs, beta blockers, MRAs, and Sj82 inhibitors. And also the diuretics are added here, that they are the class 1 recommendation in those patients who have volume overload. So that is where we are standing now. So Sj82 inhibitors, where does this journey start? It's not only a heart failure, because here you can see it starts with diabetes. The point is that in patients with diabetes, you can really neutralize risk for vascular endpoints. And I've taken this from a Scandinavian registry published in the New England Journal. And on the left-hand side, if you please have a look on the left-hand side first, you can see that compared to controls, where the relative risk is 1 in the respective age group, the control of all risk factors, this is 5 risk factors, leads to neutralization of the stroke risk. And the same picture can be drawn from myocardial infarction risk. So this is sensitive to cardiovascular risk control. And you can see below, when the risk is uncontrolled, there is a 6-fold increased risk of stroke and myocardial infarction. In heart failure, it is different. If you take a look at the right-hand side, you can see the control patients and patients with all controlled risk factors. And what you can see that there is still, although the risk factors are controlled, is a residual risk. And the risk is in the case of all controlled risk factors, when you look at younger people with 55 and lower, the risk is still increased to develop heart failure by 2.4, a factor of 2.4. And you can see that if it's not controlled, it can go up to a factor of 11. So all diabetic drugs affecting heart failure outcomes are very much welcome, because apparently the heart failure outcome in diabetes is resistant to vascular risk factors. And here are the data taken together. You can see mortality, MI, and stroke risk can definitely be reduced, while there is a significant residual risk for heart failure. Now, where does it start? So these are the first developments and the first picture of the 2 founded the Sj82 story. These are 2 chemists, one German, one French, from 1886 and 1899. And they developed that a compound from the bark of an apple tree, florizine, produces glycosuria, because that acts on the Sj82 transporter in the kidney. However, the drug also causes a lot of diarrhea and side effect. That is due to the fact that it was non-specific and also acting on Sj82, which is only sparsely expressed in the kidney, but at a high density in the gut. So therefore, of course, this was not really for the use, but now we have these specific compounds, the gliflozins, which inhibit here the Sj82 inhibitor specifically. Now, the journey started with the EMPERAC outcome trial, and this has already been mentioned by Professor Butler, and you can see that the primary outcome was positive, 14%. It was mainly carried by cardiovascular death, but expectedly not by stroke or MI, but there was a reduction in all-cause deaths and an exploratory endpoint was heart failure hospitalization. And here is what you can see, that the strongest effect is observed, which in heart failure hospitalization, which was exploratory and not even part of the primary endpoint. So hospitalization was reduced by 35%. So this was an unexpected finding, because this, of course, was something like a safety study demanded by the FDA to prove that this oral antidiabetic does not cause harm. And this was a finding here. So therefore, it was already taken up in the guidelines. So the Sj82 journey started early in the 2016 guidelines, where it was recommended in patients with type 2 diabetes to prevent or delay the onset of heart failure, because in patients with a history of heart failure, only 10% not well characterized, and in patients without history of heart failure, the reduction of cardiovascular death and heart failure hospitalization was the same. So it appeared to be useful in diabetes in order to prevent heart failure. So this was the prevention recommendation 2A, because it was not a pre-specified outcome, and B, because it was just one trial. But the situation has changed. We have now data from the CANVAS program, from DECLARE, from the artegliflozin study and sotagliflozin studies, in addition to EMBRACE outcome. And now we have a class 1A recommendation. So the patient journey should start early, already in the phase of diabetes, in order to have a prevention of heart failure. And they must not be in clinical overt heart failure. They just have diabetes, but they are very prone to develop it. It cannot be prevented by other vascular preventions, but here we have a prevention method which is independent from the prevention of vascular components. So now the next question was, does it work in patients with heart failure without diabetes? And I took this from a phase 2 study, where they looked at one of the candidate mechanisms, which is sodium excretion. And what you can see, that sodium excretion is enhanced in patients with diabetes expectedly, but also in non-diabetes. So it's a little bit less, but qualitatively, it's the same pattern, indicating that this candidate mechanism, which is very unclear whether it is decisive or whether it is crucial for the endpoint reduction or not. However, this can be observed in both groups of these individuals. So therefore, and you have seen the data, 2 trials have been developed with dapagliflozin, DAPA-HF, EMPEROR reduced. You heard a lot of this, and you can see they are very much in common. Early start of the separation of the Kaplan-Meier curves, progressively providing protection over time with 26 and 25% risk reduction. So now that were the journey through the Sj82 inhibition, starting with diabetes. Now, why starting in the heart failure area early? You can see here that the curves separate very early. And now a very recent paper by my colleague, Javed Butler, recently published in the European Heart Failure, has shown that at day 18, and you have seen it in a different way, the curves started to separate, and here is a treatment effect significant. So the upper boundary of the treatment effect is crossing the line of neutrality after approximately 18 days. And you can see relatively, it's a rather huge risk reduction by 59%, which was significant. So postponing therapies, waiting until the other drugs are in, might cause all the events occurring before or after the 18th day of treatment start. So this was one very crucial and is one very important argument in favor of starting early in the journey. And to have a little bit of self-criticism, we have to say that this was not only the case with the new trials like here, EMPEROR reduced here, or with DAPA-HF, which is the black one here. It was also the case with SOLVED, very old trial, not as early, but the trends are there, and also with EPHESUS, and also with some of the beta blocker trials, indicating that it appears to be a general principle that makes sense to start early, not to waste time until events have occurred and the treatment start is too late for the individual patient. So now the question is where to start. Yeah, here is a problem. Highest mortality is in the hospital. Then in the post-discharge phase, which is, and you have heard that very nicely in the first talk, this is a vulnerable phase and in chronic heart failure. The problem is that in the early post-discharge phase, early after recompensation, there are literally no trials. Astronaut was neutral for other reasons. Pioneer HF was quite small. Victoria were different drugs. And here we have a little bit a lack of evidence. However, the guideline committee looked at that in detail and discussed it. And one of the trials, of course, was the Pioneer HF study. And again, you can see that comparing enalapril and sacubitril valsartan, very short after recompensation, 24 hours after withdrawal of inotropes or 12 hours after vasopressors or vasodilators, you can see the curve separating very early on with a very low number needed to treat. And you can see again, postponing treatments beyond 14 days might produce events. And therefore that was put into the guidelines. What do we have with recompensation at Sj82 inhibitors? And I brought you this slide from DAPA HF. These patients have never been in the hospital. These patients have been hospitalized within the first 12 months and these later than 12 months. And you can see the closer it comes to a hospitalization, the higher is the event rate on the very right-hand side compared to the other two, but also the treatment effect appears to be bigger. Yeah, so the area in between the curves, and this means the closer treatment is started and initiated in patients with hospitalization and decompensation with recompensation, the greater is the treatment effect. And putting all that together, it turned out that this should be a class 1 recommendation. Of course, it was a class 1C recommendation, no dedicated trials. It was the totality of evidence from several trials, secondary analysis, which has been evaluated, and that was a result of class 1C recommendation. So patients should be started immediately in the hospital, diabetes and non-diabetes, when the patient is discharged without residual edema and congestion, and it should be seen after 1 or 2 weeks after discharge in order to adjust doses, to look for electrolytes and other complications, and then to adjust and control the treatment, which, however, has to be started in the hospital. So therefore, what are the problems? So in my country, there are a lot of discussion. Is that possible? So people have now raised with the point that it should be separated, sequenced, and so on. So the barriers among physicians along the journey are renal failure, low blood pressure, and decompensation. So recompensation, the fear of, again, recompensating. And this you have seen by Dr. Butler, and you can see there is a kidney protection. You can see this here at the steepness of the fall in eGFR, which is less pronounced in the blue curves with empagliflozin and steeper on placebo. And this yielded a significant difference. This translates into clinical outcomes. This is exploratory as the numbers are low, but a 50% reduction of doubling of creatinine, end-stage renal disease, or dying from kidney causes. So therefore, that point is clear. Now, people are suggesting that when the blood pressure is low, are freshly recompensated on a high diuretic dose, acute kidney injury can be a problem. So this here is meta-analysis we put together. Also, Javed Butler was on board here, and we took together DAPA HF, Emperor, Soloist, and Sugar DMS, a small trial. You can see the size here. And what you can see overall, there is a 32% reduction also of acute kidney injury. So it cannot be a barrier not to give the drug to these patients. And here it's a little bit depicted in a very similar way. To get Sj82 inhibitor excess out of 100, and 3 excess of acute kidney injury on placebo. So it's bigger on placebo. And here are the numbers from this meta-analysis. So there should be at least no fear of not to give it to these patients, because anyway, patients with heart failure and high diuretic doses might sometimes get acute kidney injury. The other point is, and this is something which we are trying to teach to our physicians, that kidney failure, patients with kidney failure can be treated. So the heart failure physicians or the cardiologist gets nervous maybe when GFR drops below 50. So that is here. But you can see here that the majority of the trials randomized down to 30, Emperor reduced down to 20, and Victoria even down to 15. And some of the beta blockers can be even given in end-stage renal disease. So the fear not to have that you cannot treat patients with kidney failure is not true. And the absolute contraindication is in end-stage renal failure for some of the drugs. And the Sj82 inhibitor, including here empagliflozin, can be given down to 20. And if then the eGFR drops on the further journey of the patients below that, it should be definitely maintained. So what about blood pressure? So here is the DAPA-HF slide, which is an illustration what happens. So patients coming through your door with a low blood pressure, they have a worse outcome. And the reason is that when cardiac output is reduced, heart failure is progressing, there is a reduction in blood pressure. And this, of course, leads to increased hospitalization and death. And the second mechanism is that those patients are less tolerant to all the drugs, the ARNI, maybe the beta blocker, the ACE inhibitor, whatever. And then this, in concert with the progression of heart failure, increases hospitalization. And now, if we are open-minded, we would say, okay, it's not only the intolerance, it's also the reluctance of physicians to use them. So therefore, there might be a problem here. So the question is, what does the Sj82 inhibitor really doing to blood pressure? This is a very recent paper from the Emperor Reduced trial. This is the placebo-corrected change in blood pressure. And the population was separated into those below 110. That is where the problem could be, 130 and above 130. And what you can see here is that in the low pressure group, where people think there is a problem, the blood pressure over time tends to increase, while there is a drop, which is, by the way, very small, only in those with a higher blood pressure. So that appears not to be a major problem. And you can see also what I've said before, the lower the blood pressure, which is down here, here is 110, the higher is the event rate. But the difference is there everywhere. Here you can see the relative risk reduction in this linear regression, we call that, and it is left of the line of neutrality, indicating that over the whole spectrum of blood pressure, the risk reduction is the same, yeah? Indicating that also when the risk is absolutely higher, the relatively risk is the same. For the individual patient, the risk reduction is greater. So when it gets tricky and complicated, people benefit more rather than less. Now, taking it together from the other studies, DAPA-HF, Emperor, Soloist, you can see it is more or less neutral. There is a nominal 9% increase in hypotension, symptomatic hypotension, which was not significant in all the Sj82 inhibitor trial. And you can see 0.5% excess, a half of a circle, meaning one patient out of 200 gets more hypotension than with any other treatment for heart failure. What about the kidney function? The next barrier and concern is my patient has a low blood pressure, so I drive the kidney into failure and no benefit is occurring. Here you can see what happened. 3 groups of blood pressure, the preservation of kidney function according to the eGFR slope is the same. No effect of heterogeneity. Here you can see the relative risk reduction. So it works also when blood pressure is low. And now when the patient is decompensated, which is another part of the journal, and I repeat here now because I find it so interesting and so important, when patients are decompensating on a good therapy or on even better therapy, you can see that those on empagliflozin, which is presumably, according to what we know, the better therapy, in addition to the baseline therapy, you can see that there is utilization reduced by 36% of IV drugs. inotropes or vasodilators, indicating that those patients decompensating on the SJ82 remain stable, and so they have less utilization of this intensive care medicines during hospitalization. Now, having said that, the question is how to layer. So people said sometimes here and in Europe, it will not work because they all have blood pressure effects whatsoever. We try to put that together here in a group, and there is a second paper from the Heart Failure Association. This is a problem on the left-hand side, decompensation, recompensation, early post-discharge, and chronic. Here the outcomes are high, the treatment is poor. Then it gets better, outcome less, more treatment intensity. And there could be an individualized phenotyping of the patients. Relevant is blood pressure, AFib, yes or no, kidney disease, yes or no, and heart rate. So for instance, the big four should be given as possible, starting according to this profile. And then when the blood pressure, for instance, is low and the heart rate is high, then preferably reducing heart rate because the expected size of the treatment effect is rather high. Beta blockers, ivabradine, maybe together because they can even facilitate the uptitration of the others respectively. And then you can move according to this 4 criteria to all other drugs. You can layer the treatments according to this. And the goal is to have, in a very short time, the maximal treatment which is possible applied in a patient. So taken together, we have a strategic change, which means starting the C4 foundational therapies all together. Important point, I frequently ask questions. SJ82 inhibitor indeed does work in diabetes and non-diabetes, no different at all. The early journey is very important. It can prevent incident heart failure in patients with diabetes. In the late journey, it protects the kidneys, it works at low blood pressure and low eGFR, and then all effects start early and become positive early. So therefore, it should be started in the hospital with a very easy uptitration scheme, and the patients can be treated according to a layering, which takes into consideration the individual patient phenotypes. With this, I would like to thank you for your attention. Thank you.
Thank you, Michael, for this excellent clinical overview of SGLT2 inhibitors. So now I think we'll have the floor for discussions and questions. And I think I see the Q&A is many with the questions. We'll start. First question by Dr. Mustafa Shememri for Dr. Jabed. What was the incidence of hyperkalemia in the reduced study?
Yeah, so that's interesting that SGLT2 inhibitors, there are some data may actually help enable MRA, that the overall risk of hyperkalemia with SGLT2 inhibitors is actually lowered. In EMPEROR reduced trial, the threshold of 5.5 was almost the same between the two groups, but the threshold of 6 was almost statistically significantly lower with empagliflozin. So in the best case scenario, there is no impact on potassium, but it may actually even lower the risk of hyperkalemia.
The second question, does EMPA will improve ejection fraction?
Yes, so there are 3 studies out now, 2 in diabetics, 1 in non-diabetic patients. All 3 of them are published, 1 in CIRC and 1 in JACC, showing that there is reduction. So in heart failure with reduced ejection fraction, there are studies that show that the volumes go down and the ejection fraction goes up. And in hypertensive patients, there is data for reversal of left ventricular mass as well.
Good. Okay, this is another clinical question. Maybe Professor Michael will answer this. I would like to ask, when I treat my patient, what use my first option to start, spironolactone or empagliflozin?
Again, you can start it together. Maybe not, if there is a blood pressure problem, you might use eplerenone, which in meta-analyses have shown to be less potently reduce blood pressure, but there is no reason not to do it together. there is evidence that, of course, the hyperkalemia is less reduced on the Sj82 inhibitor. So there is no reason not to start it together, right?
Okay. Okay, that's answered the question. And the other two questions about, maybe Professor Javed answer this. What is the risk of amputation and urinary tract infection? And can we use EMBA in patient at risk of UTI?
Yeah, so there were some earlier studies with only one drug, canagliflozin in canvas, that there was a risk for amputation. The absolute risk was very low, but the relative risk was high. Since then, there are literally like 60, 70,000 patients in like 15 trials that have never shown a problem with amputation and fractures. And in Emperor Reduced, it was still the same. The risk for amputation was less than 1% and was matched in two groups. If I remember it correctly, it was 0.5 and 0.7 or something like that. In terms of the UTI, again, the same thing. This drug does not increase the risk of sepsis or urinary tract infection. What it does increase the risk is of genital mycotic infection per se. And that's why the recommendation for keeping the area dry and clean and good hygiene. But the UTI risk does not increase. Again, this is all published. I'm speaking from memory, but I think the risk was about 4.5% in both groups, no difference between the two groups.
Good. Another question, either Professor Javed or Dr. Morsi can answer. How accurate the use of a quality assessment score for heart failure?
So I can take the first step. So, so I don't know how to describe the word accurate. So there is a lot of inter-observer coherence. So there's not a lot of variability. So if you take the same test and repeat it in 3 days or 4 days in a time frame when there is not a change in patient symptoms, these are very reproducible. Now, in terms of what does it translate? So as I mentioned, a 5-point difference measures for about 100 meters of extra walking. And the subtle differences over time, not 2-3 days, but in 2 weeks, 4 weeks, 6 weeks, then correlates with clinical endpoint as well. So if your scores are getting worse, there's a higher risk of hospitalization mortality. If the scores are getting better, there's a less risk for mortality hospitalization. But what we are trying to push, or what we're trying to advocate for, is not necessarily using these scores as a marker for prognosis, but using these scores in themselves with quality of life being an outcome itself.
Okay. Another question to Professor Michael. What happened if we double the dose of the EMBA or DAPA?
Not much. We have the Renal Outcomes study, and they compare two doses, 10 and 25 milligrams, and there was absolutely no difference. So the curves are superimposable. Therefore, it was decided to take for the heart failure studies a 10 milligram dose. So there is no reason to use a higher dose. In some obese diabetics, where you really want to get rid of the glucose, then there might be a reason to take a higher dose of empagliflozin, but not in heart failure, and might not even be relevant or advisable in patients with diabetes. 2 doses are approved for diabetes. In heart failure, it's 1 dose, 10 milligram, no differences in outcome.
Yeah, and I think both Professor Javed, Professor Michael enlightened very nicely about the use of SGL2 in renal impairment and with the creatinine clearance. A question about in renal failure dialysis, has any role or no data on that?
So there are ongoing trials to get some data, but right now it's actually considered a contraindication when you're on dialysis, because we don't know the whole detail of the PK/PD studies. So it is bound by albumin, so it is not necessarily easily dialyzable. So we don't know the half-life or whatnot. It makes a lot of sense because these patients are at a higher risk of cardiovascular events, and this drug does not cause hyperkalemia. So it makes sense, but today it would be a contraindication till we get more data.
Okay. Is another question, maybe it's, is it a class effect, the SGL2? Is any different? Is any the best, asking how the best SGL2 for heart failure prevention? Is it the class effect, or is any different between SGL2 inhibitor?
I think it's a, Javed, you want? In my view, it's a class effect. The companies sometimes discuss a lot about differences because one endpoint is more strongly reduced than the one in the other trial. Its cardiovascular death was nominally reduced in EMPEROR and significantly reduced in DAPA-HF. However, the kidney endpoints are more significantly reduced in EMPEROR, not in DAPA. This is simply due to the, Javed, correct me if I'm wrong, but this is due to the study design. So in the middle of the observational period, there were 1,000 more patients in DAPA-HF, and that means for the more rare endpoint, it was better powered. There is a meta-analysis showing no heterogeneity between DAPA and EMPEROR that was published shortly after the first presentation in the Lancet. And the kidney endpoints are slightly different because DAPA randomized at a lower eGFR, so it was easier to achieve them because they were not so far away, these patients, to get end-stage renal disease than in DAPA. So it can easily be explained by treatment designs, yeah? And so in my personal view, this is a class effect very clearly.
I mean, this is always a difficult question to answer because as a clinician, I really like the concept of class effect and completely agree with Dr. Bohm that that's the way the data are looking. The problem is that we have a lot of experience that when we assume class effect, but we check different drugs, then you don't get the same effect. So for instance, with beta blockers and heart failure, we know that long-acting metoprolol, corvedolol, and bisoprolol improve outcome, but bisindolol and nebivolol did not. Similarly, in the field of diabetes, we know that with DPP-4 inhibitors, with saxagliptin, you actually worsen heart failure risk. With alogliptin, also it was going in the wrong direction, but with linagliptin and sitagliptin, you did not see any angle. So my best answer is that if possible, just stick with the drugs where the evidence is. But if it's not possible, then giving something is better than not giving anything.
All right. In the beta blockers, there is also pharmacological differences like beta-1, beta-2 prevalence, intrinsic sympathetomimetic activity. And I cannot see that with these two SJ82 inhibitors, which both have generated similar evidence. Yeah,
absolutely. So evidence-based is perfectly fine. The problem that I run into is that there are many SGLT2 inhibitors that have never been tried in any study. And that's where you run into trouble when you give a blanket class effect.
Completely agree.
Yeah. Other question about...
I want to say something about EMPA and the diastolic dysfunction indices parameter improvement. Any data supporting, especially in heart failure patients with the advanced diastolic dysfunction indices parameter impairment? Any data?
I think there is Javed, there is one meta-analysis E2E prime, which was reduced, but I don't think it was a very small study, which was not it was prospectively tested maybe, but not in a core lab. So it's on very soft turf, very, not very reliable, I think. Yeah.
I need to look at Subodh's data. So in hypertensive LDH patient, there's LDH reversal. I don't exactly remember the diastolic parameters, but if there is LDH reversal, you would assume that the diastology got better.
Okay, another question from Dr. Sayed. Does the SGL2 inhibitor impact the sodium level?
Not that I know of.
No.
Okay. Another question from Dr. Kamal. I think both of you guys answered that. Which should in de novo, which should I start first? ARNI or SGL2 inhibitor? I think this has been answered. Anybody want to take that question?
So I can take the first step. So I would say that let's first get the science right, because one of the things is that, heart failure, we were treating all generic medications, right? ACE inhibitor, beta blockers, MRA for a long time. And now there is sort of this inherent competition in terms of cost. Both ARNI and SGLT2 inhibitors are not generic. But remember, at one time, ACE inhibitors and beta blockers were not generic also. And at some time in some intermediate future, 2, 3, 4 years, SGLT2 and ARNIs will not be trade either, and we will get generic. So let's just get at least the science right. And the science is that we cannot pick and choose. You need to really give the 4 combination therapy. Having said that, at this point, my bias would be to just use it best to your patient. You know, if somebody is low blood pressure, more dizzy, then starting with SGLT2 inhibitor makes sense. If ARNI is available and you want to go with ARNI first, it really doesn't matter as far as you can get all the drugs on board.
Try to do it simultaneously, yeah, because and do these maybe patient profiling. If the blood pressure is high, you can start with the 2 of them. If the blood pressure is low, it's easier to use as a clinician SGLT2 and eplerenone. If the heart rate is high, then ivabradine plus beta blocker, and then slowly up titrate Zakuval, but do it into days and not weeks or months, yeah.
And I think I agree, and there's the editorial about the Fantastic Four, and I think we have in our hospital, our center is a pathway. If patient in heart failure not in this 4 medication, we have to ask ourselves why not the other way around, rather than we have to start it because the evidence is overwhelming. The last question I have, I think, from the audience about, I think mechanistic, asking a question, can you explain the transient fall in the renal function when we start SGLT2 inhibitor?
Michael, do you want to take it, or do you want me to?
I can take it. I start with it. So there is something like a tubular glomerular reflex. So there is more sodium appearing in the beyond distal to the nephron, and this is sensed by the juxtaglomerular apparatus. And then there is a relative constriction of the vas afferens, and also a dilatation a little bit of the vas efferents. So the filtration pressure in the glomerulus is dropping, yeah, right? So that is a pharmacological effect, a drop in the effective filtration pressure, and this gives you this early dip. So this is not kidney disease or something. This is a functional pharmacological effect, because when you get off the drug, it comes up again. And if you go off the drug, maybe after the treatment period, approximately 20 months, it goes up on SGLT2, but it stays down on placebo, because then the kidney got damaged. So the true difference is what you have seen in the figures from Professor Butler, the crossing of the curves, the difference, but you have to add at the very end the drop on empagliflozin, and that is a true saving of kidney function. So that is the mechanism of it.
I can just add only one statement. The main cause is called afferent to efferent mismatching mechanism, to make it easy.
Yeah.
Okay. Last question from the audience, another interesting question. SGL2 and asymptomatic NYHA class 1. And I might add it also, is any data in HFpEF also?
So I honestly don't know what is NYHA class 1. I think more often than not, NYHA class 1 is a clinician not taking a good history. If you really look at the patients and ask them to exercise, you will see one of the 3 things. Either the patient is really limited, or you just take a history that they have lowered their expectations from their life, or they're asking somebody to help them. So if you take a good history and do any objective testing, and by objective testing, I don't mean treadmill, or just 6-minute walk test in the clinic, they are very reduced. I would say I see probably 1 patient a year, which is, you know, a 28-year-old postpartum cardiomyopathy who's bicycling. Most of the people are symptomatic. Having said that, if you truly have objectively asymptomatic patient, then right now, we don't have any evidence for treating those patients. The clinical trials were on symptomatic patients. And in terms of HFpEF, I mean, we already have a full 6,000 patient trial with empagliflozin, which is positive, showing benefit again for the first time, any trial which is positive in HFpEF.
Good. One other question about, would you adjust the dose of diuretic when you initiate SGL2, or no need to adjust the diuretic dose?
I think I would do nothing after adjustment of the dose. First, look what happens. Yeah, I mean the diuretic effect and also the augmentation of the natriuresis is not so strong that you really can have first hypovolemia. We have done the same meta-analysis in hypovolemia. This is also non-significant, minor, right? And also no drops in sodium because these effects are so small. So in the long run, it might, and there are data on that in DAPA-HF as well, the need for up-titration of loop diuretics. And Professor Butler has shown also a set of data on that. That is also in EMPEROR shown. So I would not adjust anything, just initiate and then control the patients. And if you do it in the hospital, as the guidelines say, control it after 2 weeks. If there are problems, you will see that.
Okay. Any other question, Dr. Morsi, you have? I finished all the question. What about, just one question I have about in acute heart failure in ICU on inotropes, patient already on EMBA, would you hold it, change it or not?
So these patients are usually fasting, yeah? So they are in a cardiogenic shock, so they are in a metabolically challenged position. So in these patients, it should be not continuously withdrawn, but it should be paused. That's the way I would do it.
Okay. Great. More question coming.
But again, to Dr. Boehm's point, you know, if you are not eating, your NPO for some reason, or you're too sick and your appetite is down and holding makes sense. But we do have an acute heart failure trial as well, where the drug was given in the hospital setting, was initiated, and not only the clinical outcomes got better, but quality of life, and it was very safe, and there were no new side effects.
Okay. Okay, I guess you guys answer all of the question I have, and I think we have a very nice evening. It's we have more than 60 audience here, and it's 10:30 in the evening in Saudi Arabia. Thank you very much. I'd like to thank Professor Ayman Morsi, Professor Michael Boehm, and Professor Javed Butler for this excellent webinar about SGLT2 and heart failure, reduced ejection fraction. And I thanks also Boehringer and the Saudi Heart Association for hosting us. And finally, I thanks our IT, the Konaz Ritaj, for making this possible. Thank you for you all for that, and has a good evening for you all. Thank you very much.
Thank you very much. Stay safe.
Thank you very much. Thank you.
Bye.
Bye.
Bye.